You're welcome, Dr. Scotty. Well, thank you for bearing with us. I'll be a lot briefer than what was announced because it's late. And also because what was supposed to be an introduction to the presentation of the barometer and the discussion we've just had, you'll see that there's a lot of elements that have already been touched upon. So it will be a kind of picking up on the discussion we've just had. Florian asked me to present you with what we actually the takeaway messages from the Palliative Care in Oncology Symposium. And so just my disclosures. And back to the heart of the matter, it was the very first symposium, inaugural symposium. It was a real success. It's important to mention that. There were 700 participants, and well, it was organized for 700 participants, so it was sold out. They've had to say no to some people. 272 abstracts were accepted. 75% of American participants. That's only natural because 3 out of the 4 societies that had got together to organize that symposium were American. And amongst the non-American abstracts accepted, ranking first, France. So, you know, well done. Hip hip hooray, and so on and so forth. So 4 societies co-organized. There was the Asco, and an American, which is a multinational, the MASC. And you'll see that it kind of dovetails nicely from the discussions we've had today. And one of the takeaway messages for me was the debate between palliative care and supportive care. And let me remind you that we were fortunate enough to be able to report live from this symposium. Thanks to the Ospira lab, and I'd like to give thanks to 2 different stakeholders. The labs that support us, quite often these reports, when we see the number of people who read them, it's a great means of informing. So many thanks to the labs who support us, and many thanks to Ospira for supporting us on this online report. And it was the first, so nobody knew what to expect. Palliative care in oncology was the title. Of course, we are experts in supportive care, but we tried to find out more before we went, but Ospira took the risk. And when we see how many hits we had with the e-journal, well, they were right to trust us, and Florian was right to insist. It was a real success. So at that point, I was faced with a problem because Florian asked me to tell you what we took away from that symposium, but at the same time, most of you probably read the e-journal and downloaded the slides and listened to the interviews of major international leading figures that were published on the site, so I thought I would not do that. I would not repeat what was already in the e-journal, but I'm going to tell you about what Jean-Baptiste, Florian, and myself took away from it, and what I took away from it, and what our impression was, and as a red thread, the debate about palliative care versus supportive care. And that was really the red thread in the whole symposium. Patricia Gantz presented this as part of a general session in the plenary. She presented the definition of palliative care on behalf of the organizing committee, and what was presented, as it was said before in our discussion, is that to them palliative care starts from the diagnosis, and it then is implemented around two notions: the long-term effects, so adverse effects that start during cancer treatment and then continue a long time afterwards, and the late effects that start afterwards and sometimes a long time after the end of the disease. And that brings to one conclusion, is that palliative care, using that definition, is going to require assessment and follow up on a regular basis. And by acting on the 3 Ps, palliation, helping with fatigue, with pain, and with psychosocial impact; prevention, so prevention of secondary cancer and of complications linked to cancer or cancer treatment; and health promotion, which should be set up as early as diagnosis to prevent complications, to give support to patients, and to enhance their quality of life. That's what was presented as a definition of palliative care at that symposium at the plenary.
So now there are a few slides over here that you have. You've got it also on the internet. You've got the entire pathway of the customer, from diagnosis, treatment, right up to relapse, and then completely on the right with the risk evaluation, diagnosis, the possibility of relapse, etc., and treatment used for the management of this disease and its side effects. So finally, there's also an intervention on the choice of treatments, curative treatments, depending on patient profile and, of course, on potential risk that he has of a more proactive intervention on the kind of treatments that should be taken containing toxicity or with a toxicity profile which is a priori better accepted for a given patient. So that was essentially what I showed you on the earlier slide, and I've put it back over here to show you how they were assisted. And I must insist on it that palliative care in this Congress starts with the diagnosis of cancer itself. You're no longer talking about palliative care being terminal stage or end of life and right up to death. So this is what you have over here. Can I have a pointer, Dr. Scotty? Gone. All right, so we'll do without it. Now here you have, and I'm just sharing what was shown to us. I'm just a reporter over here, so I'm reporting. This is the old definition of palliative care, and here you've got the curative or life-prolonging treatment, and here at this side, towards the end of life, this is palliative care, which is playing an important role. And here's the present definition, which is what was promoted and presented, the new one. So you start right at diagnosis with palliative care, plus there's an implementation both in quality and quantity, depending on patient needs, which grow as the patient continues or progresses right up to the end of life, where there's 100% palliative care management. That's what was shown to us. So why do we have different words, palliative care, supportive care? Because what we were shown is that, and it's between inverted commas, palliative care in the U.S., and because it's especially in the U.S., this is care that's provided right through the disease. Because in Europe and France, it's what we call the supportive care. And what we call care at the end of life is really palliative care. Then finally, there isn't much difference between supportive care in France and palliative care in US. So why do we have different words? And this is a question of interpretation. And this is a personal interpretation. I feel, and this is just my personal opinion, that they use a different terminology, because if you don't have supportive care, there's just one reference organization, there's one reference congress, there's one reference journal, and that is the MASC. which was set up by about 25 years ago. So perhaps it's very difficult for Americans, particularly for their very first supportive care conference, to confront supportive care straight off. And maybe that's the reason why we have all these different words, all these different definitions, which are finally all the same, but which refer to radically opposed terms. So the president of the MASC spoke several times during this conference because it was a co-organizer, and his representation, and it's not the first time that MASC is actually making this presentation, we find here at the bottom, and this is the American point of view, you've got the supposedly curative cancer therapy, and then the gradual development of palliative care right up to death. And all this is in the framework of supportive care, which has just as much importance, covers the same needs, and in terms of quality it changes right from diagnosis right up to death. And I hadn't really thought about it, so I must mention it, because your comment that you made, that you might have from supportive care to palliative care, because we have chemotherapy and radiotherapy for palliative care reasons. Maybe that's maybe what they wish to say when she shows this graph like this over here. So what are the lessons to keep in mind? It all depends on who you are. Now, either you're a specialist in supportive care, and a purist at that. In that case, there's a real difference in ideas, and we must take a look at all these ideas, all these different positions, and be involved in this discussion, because there's a real competition. But this is my point of view between these various scientific societies. But it doesn't matter, it's all the better. That means that supportive care and that patient care, not just curative care of cancer, is becoming of interest to everyone, because scientific societies are fighting to become the reference in this field. Now, for non-specialists who just want to treat patients, which in itself is fantastic, just remember that in America, palliative is not the same as palliative in French. So that means that the Palliative Care Congress is a supportive care Congress, actually, and even if we are not specialists in palliative care, we should be interested in supportive care, and so you shouldn't be put off by just the terminology. Now, that might seem ordinary, but it has been proven, quite originally by Edward and Richardson, that sometimes terminology can put you off. So you have what we call now, Edward Brera changed the name to Ambulatory Unit for Supportive Care. And it changed from the Ambulatory Unit for Palliative Care. It turned into supportive care, according to different criteria. So Eduardo Brera, who talked about it several times, he said this change in name from palliative to supportive had a huge impact on the activity. On the left, you have the number of annual patients that were referred to palliative care. That's what it was called then. And then you have the growth in the number of patients per year once it was called supportive care. In 2013, it's 1,225 patients per year, as opposed to 750 when it was called palliative. It changes doctors' perception, who hesitate less to refer their patients. And this is in the US, despite everything that's been done regarding American palliative care. Now, the second good result is about the typology of recruitment of patients who are sent to supportive care. You also have the survival, or total survival of patients, when it was palliative and when it was in support. And as you see, there's a difference, a major difference in patient survival. It's much better when you call it supportive care. Now, has the kind of care changed? No, it's not that. It's the patients who have changed, because they're more interested in the history of their disease, since it was called supportive and not palliative. And Brera says that he also has patients who You reach the adjuvant stage, advanced or metastatic, not just advanced or metastatic cancer. So there is a change in perception just because you change the name from supportive, palliative to supportive. I think this is very unique and very original. Now, the president of the MASC also shared the vision of MASC. And here there are 3 points which I feel are very important in what the MASC has to say. There are 25 or 30 slides which are all very interesting, but I don't think I'll show them all to you. And these points are as follows, particularly as far as MASC is concerned. Supportive care includes prevention and the management of side effects of cancer and cancer treatment. And supportive care in cancerology comes into play when there's an early detection. This is still prior to diagnosis, right up to diagnosis, during the curative treatment, and this includes the post-cancer stage. It includes palliative care and also end of life. And in one slide, she also talked about post-mortem, which meant support for the grieving family. So this is just a sheer physical and psychosocial load which is being shared. It's extremely important. This is a major point when you're thinking of adjuvant care. And now I'm insisting on prevention and management of side effects, considering cancer treatment. We heard somebody, Brera, talked about symptom management, and that is that's just symptom management, which is a very important part of supportive care. They summed it up in the 3 M's. We had 3 P's in palliative care. Now we have 3 M's. So these 3 M's are quite simple. To do a proper and appropriate and effective management of symptoms, you must know the mechanism of the symptom and of the toxicity that you're treating. The effect, be it secondary or cancer, multiplication, etc. You must know the curative treatment. This is about treatment tolerance, that it's all about, of chemotherapy and targeted therapy. We must also measure the potential clinical impact of the toxicity and its effects. If there is a low potential impact, it's not necessarily a priority in the therapy decision that will be taken for a given patient. If, on the other hand, the clinical impact is going to be major, in other words, that it might in fact affect the vital signs of the person, then there will be a complete management as best as possible from A to Z. And then finally, it's the patient who's most important, as well as the clinic. It's not a question of quantity. We are not trying to have as many interventions as possible in supportive care, just those which are absolutely necessary for a given patient. And the 3rd M is about toxicity management. It sounds silly, but you must know and be able to actually manage them. By that, it means controlling them, treating them. So you need the right drugs, perhaps, to treat side effects, because it's a must. You must have interventions which may be non-medical. You must also be able to prevent them, because if you have a patient at risk after a certain adverse effect, and you have to give him this particular treatment because there's no alternative. I know of a patient who had a very severe renal failure, and he still had to be given cisplatin, and you have to inform him of the toxicity so that if required, you avoid dialysis and have even worse effects. Now, for several years in cancerology, we are just living with these toxicities, and now in these last 25 years with MASC and supportive care, we have learned not to just rest on our laurels and also deal with these toxicities. So maybe I'm just, these are just wishes, but it should be our new aim. And then also there was nothing new over here, but for instance, what I'm showing over here is on the aromatase inhibitors. AIs. And this is just a little while after diagnosis. So you start patient education You look at risk factors, monitoring of risk factors, side effects, particularly things like arthralgia as related to AI. Here we are talking about monitoring in order to see when it's necessary to intervene. This is necessarily about prevention of toxicology, and if there is a symptom and if it is of mild arthralgia, maybe just mild exercise would help. So this is all non-pharmacological but have shown certain benefits. And in case of severe arthralgia, maybe there should be a change in treatment, a substitution, and have some other treatment, inclusion in maybe clinical trials, and have maybe adjuvant treatment like acupuncture. There was another presentation which showed those 3 M's very clearly, and this was about fatigue related to cancer, where the speaker began by talking about the physiopathology of fatigue in cancerology. So you have to understand the mechanism of side effects of cancer in this case, and not just of its treatment. So there were details about this physiopathology and why we have fatigue, plus targets with certain cytokines, which could perhaps be future targets, therapeutic targets that could be developed. And then the speaker spoke to us about Asco and about fatigue management in cancerology at 2 levels. Level 1, which has one key message, which is extremely important and simple, that you must assess. It's just like all side effects. You must assess whether if there's nothing underlying. So you have standard treatment. Standard depends on who's providing it. And then again, a complete and regular analysis or evaluation of fatigue. So if it's between 0 and 3, the idea would be to continue monitoring. In other words, keep doing a regular checkup of fatigue in these patients. And when, for instance, fatigue is scored at 4 to 10, which is moderate to severe, then there is a greater an assessment of fatigue. And this takes us back to the 3 M's to see the origin, the mechanism of fatigue in these patients in order to have a better supportive care implemented, which is necessary for the patient. At the second level, and this is true for all patients, you must provide health education. Talk to them, explain exactly what fatigue is all about, and say that it isn't something common or ordinary or banal. It's not just a passing fatigue. You talk about it to your oncologist, your pharmacist, or your nurse, and there are solutions to give relief. Of course, it's not 100% efficacious, you see, but there are solutions that can be provided. If the patient doesn't know and he cannot find relief for fatigue, then you can perhaps reduce it to a certain extent. There are things to be tested. But if you don't really talk to him about it, then he's not likely to discuss it with his patient. And when it's a very severe fatigue, and then you look at all the contributive factors. And so we recommend intervention, which according to Asco are based on empirical items like exercises. But we have absolutely no controlled trials, but we have data which goes further than this. And then there is the complementary therapy like acupuncture, which has proven to be pretty good. Now for anemia, I talked to you about contributive factors. Anemia is one. It's not the only reason, but it is a contributive factor, a major one. It's essential in certain patients, and they discussed it at the Oreo results. More than 2,300 patients treated with the biosimilar ASE were included. There are 2 visits of evaluation in the first 3 months after starting treatment, and the second between the 4th and 6th month. So very briefly, let me show you the bits which I find very interesting, and that was anemia management during this Oreo study. And this goes back to what you heard a little earlier, about neutropenia, because if you don't really follow up, there's no guidelines are good, but you must follow them up. So this is the international guideline of AFSOS on anemia and cancer. Underneath, you've got links that you can download as easily if you wish to. There are two major points which are also very, very important in these guidelines, which were tested, in fact, in the ARIO study, and the idea of management and anemia management in the Oreo patients is that AFSOS very clearly recommends that it is necessary to individualize treatment in order to maintain the target hemoglobin with the lowest possible injection of anemoerythropoietic agents. So here, this is, what is your hemoglobin rate? Is it above 12 or below 12? And you see that virtually half of them say less than 12, and those who say it's equal to or higher, this won't tell us much about the recommendation of AFSOS, because in the reference, in the guideline, they are saying about 12 grams, which is the European recommendation. So around would be a little above, a little below 12. So that's the case for this percentage of patients. So that means they are willing to perhaps to live with a lower hemoglobin. There's another message, and that is about a tailor-made treatment. This is very clear. We don't do this in France. There is no tailor-made treatment here. Here in the middle, you've got the percentage of patients who receive a stimulating agent for erythropoietic, and this it's on the basis of patient's body weight. Now, for 21% of patients, the total dose related to their weight was too low. More than 20 are underdosed in this, and the rest of them are overdosed in RSE. So the total dose that they received is not related to their weight. So they haven't followed the guidelines, at least in the clinical practice. At least it's not efficient, and so must be spoken about greater to more patients. And the third point in the guidelines is the addition supplement, an iron supplement and ASE. So if here again the guidelines are very clear, there should be injectable iron prescription, and with Oreo, what did we have? There's absolutely no iron prescription for these for nearly 76% patients, and those who had this kind of deficiency and who were given an iron supplement, you find that 61.4% of patients who were given oral iron, whereas AFSOS says it should be only intravenous. So now, have they really done it in practice? Here you've got the results. And this was carried prior to the starting of treatment of ASE, and it was only in 25% of the cases. So the recommendations of AFSOS of making sure that they be given iron has not been done. So they require a minimum of a biological test. All the tests being done is not being done. Anemia today is still very frequent in patients suffering from cancer. And at the last Mass Congress, we found that there are lots of analysis done. There are 3 studies that were carried out, and over 10,000 patients, more than 50% having cancer between 2004 and 2011. So they're being managed today, and more than half of them have a lower hemoglobin than 12. So anemia is a major problem. We tend to forget all about it, or we want to ignore it, but it should not be ignored. So let me end here with this. Now, she herself, Jennifer, involved in early, Jennifer Tabel, did a video interview, and you've got this. If you like, you can check it out on the site. And I think Floria made this presentation. She is really the leader in this field, and I think she's going to be the only one, because it's very difficult now to see studies showing it. Now, she did was called early palliative care, clearly supportive care, which improves survival, particularly in lung cancer patients. Though, of course, this was not the initial endpoint, but it was very significant in 2010. And after that, several other studies were carried out. So Jennifer showed us results of other studies that were carried out, and this time regarding quality of life. So this clearly improves quality of life. You see results over here of three major studies that were carried out, which look at the impact of early palliative care on quality of life. And for most of the scales for assessing this impact on quality of life, we have in green over here a major improvement of the criteria that is studied in patients who receive early palliative care. And in another study, still by Jennifer, they showed us that management of early or introduction of early palliative care once the curative treatment starts doesn't cost much more than the traditional patient management. It isn't cheaper, there is no saving, but it doesn't cost more. In fact, there's absolutely no major difference for any of the criteria. Here you've only got some. There's absolutely no difference when it comes to the financing of it. Jennifer Timmel finishes, and I'll also end with this, with some considerations which I feel are very interesting. Her reflection was that this kind of supportive care requires that it has to be started very early, but it must be individualized according to patient needs. And Jennifer asked two major questions. She says, when we talk about individualization, do we take into consideration a general population or a single person? Do we look at the kind of cancer and where exactly it is located? Or do we change the approach? If it's a lung cancer, pancreatic cancer, a melanoma, breast cancer, I think yes, you'll all agree with that. Because according to what they have, their needs are different. Second question that Mrs. Timmel asked was, will it be the same early palliative care in terms of quality and of proposals that you make to the patient, no matter who the patient is, and independently of the tumor? It's just based on symptomology. So this goes into the 3 M's again. This patient has a cancer with a very difficult symptomology, and second, clinical management becomes very difficult because it's a question of life and death. Now, Jennifer says that in this particular case, it should be palliative care for 100%, and it should be longitudinal for all patients and very frequently. And then she goes on to say there are 3 other situations too. Personally, I believe that we can adopt another approach also, and that's what we are working towards. Perhaps we should have a discussion on it, because I'm not sure if we are ready today. You've got people suffering from cancer, and you will find that I haven't underlined the fact that she's set up the system for patients with advanced cancer. I cut that out. There is a need in oncology for supportive oncology and adjuvant treatment. There is a real need for these patients. And then we have just patients, not just individuals. So this comes to patient-centered care that Florian spoke about. And this is the direction that we are taking. We are trying increasingly to what is the kind of ideal oncological supportive care, depending on the kind of tumor, the severity, the stage. All this makes it more complicated, and we are also trying to define at the same time a more customized palliative care for patients depending on his physiological, psychosocial needs, plus including the comorbidities that he might have. As we said, it's an aging population, and now cancers being diagnosed at a later stage, you have all sorts of problems of osteopenia, other endocrinial problems, other neurological problems. So comorbidities and kidney failure, etc., like kidney failure, which is becoming increasingly widespread. And in these last 5 years, in these 4 years actually, in the French classes on breast cancer in Nice, This is only about breast cancer, but you have courses on synology. You've got the next session over here, time, etc. And where it is, this is in January. There will be next year a palliative care in Oncology Symposium. You've got the dates here, 9th and 10th of October in Boston, but we've just changed the hotel there. And and I'd like to thank all of you who made the hits on this particular site. It was very high. Everything is accessible. If you get on that site, everything is available, articles, photos, videos, etc. And there'll be a journal also on palliative care in 2015, and this is the last one. So patient-centered care is very important, and that is cancer toxicity management, which is also the subtitle of our TAO today. Thank you. So you have, what is this bias you're talking about in patient selection and treatment and so on? Now, MD Anderson, they've gone from 750 to 1,200 consultations, so there must have been other services also who are doing other things in the same field, because this is just in a small hospital. Sorry, I hadn't understood what you were saying. Yes, 1,000 patients a year or consultations is very small, yeah, given the entire unit. But what's interesting is it's not that they're just they've got too many patients. It's the difference, between 750 and 1,000 patients in 5 years, which is, yeah, but there has to be a functional bias in it. It could be for any reason. I'd like to understand the reasons. Maybe there are 3 other departments who are doing something else, something differently, something less. It could be anything. This is just a sample which is too small given the size of this hospital to come to any kind of right conclusion, unless, of course, it's a financial thing and we have going from 750 to 1,200, and so I need more nurses. I just don't see the sense behind it. You mean that they should have looked at the kind of patients that they had in other departments or wards also? Yeah, because I don't get the message over here. I don't really get it. Well, for me, the message is clear that at the same level of care, etc., that same means, same offer, same everything, all that we've done in the same hospital like Anderson. And here, once again, what I'm talking about is this relative data, is the increase of 60% in 6 years of the number of consultations. These were consultations referred to by other doctors within Anderson. And so the awareness that was made of this general approach to supportive care. It's a huge hospital, and you've only picked one part of the jigsaw puzzle, and I don't think it makes much sense. Okay, it's your point of view, sir. Well, Brewer's idea when he showed this study was just the consultation of his department, of his unit, and what he was saying in his message was that the number of patients who came in because they changed the name of palliative to supportive is because they were less scared of the title supportive. It's not that give us more money or whatever it is. The idea was to say that if I change the term, then it's something more positive for both patients and the practitioners. You cover more patients, right from the time of diagnosis. We're not looking at the general business or activity or financial aspect of it in this Anderson hospital. It's just that the change in term is useful, just to make the service more useful.